Aparna, it's all yours.
Thank you, Ram. I wish I could always speak so nicely and clearly like you do. I do, like in fast pace. But it's such a pleasure to introduce Alexis Malkin, who goes by Lexi. Lexi and I were classmates in optometry school. She was then and continues to be one of the most outgoing, driven people that I've met in my life. Lexi received her optometry degree at the New England College of Optometry, followed by a residency at the VA, at the Northport VA, and also did a fellowship on vision rehabilitation at Johns Hopkins. She is now an associate professor of clinical optometry at the New England College of Optometry, and her focus area is low vision and vision rehabilitation. A rising star, a pioneer in the field of low vision, with many accolades achieved at a young age and many more to come. Thank you so much, Lexi, for being part of this webinar series for Vision Aid. She will be giving her talk on overcoming barriers to low vision care.
Great, thank you.
Thank you, Aparna. And I'm going to stop sharing my screen to let you share your screen. And I will also mute everyone, so please unmute yourself before you speak. So just give me a moment. Just hitting that mute button. So if you can please unmute yourself and share your screen, we can get started.
Okay, hopefully my screen looks okay there.
Yes, we can see your screen and I can hear you as well.
Perfect. And I'll let you guys watch the chat feature. I have that minimized, so. Okay, well, as we said, good morning, good afternoon, good evening, depending on where people are. I wanted to talk
Oh, did we lose Lexi?
Yeah, it went away for a second and it just came back.
Oh, okay, I don't know what happened there. I don't see a slide as well, so maybe you can share it again.
Okay, we should be back.
Yes, yes, okay. I can see your screen, I can hear you.
All right, I don't know where it cut off, but I'm going to talk a bit about the strategies we've used for overcoming barriers to low vision rehab. One of the things that I'll talk about a bit is just kind of the background on who the patients are with low vision. Some of this may be familiar to some of you, but I want to make sure that we set the stage and that we're all coming at the information kind of on an even playing field. So I think we all are aware that there's a general shortage of low vision rehabilitation services. This is both in the United States and worldwide. We also know that there is a growing need with increasing incidence and prevalence of low vision with a general aging population. And some of the challenges that come up through surveys of providers and even as a practitioner are that the aging population here in the US often has reimbursed insurance rates, reduced insurance reimbursement rates. So some of the challenges with ensuring that people will get paid for the service they're providing. There are concerns with the long chair time required, and that patients with low vision often have a higher than average no-show rate, related to transportation issues. It's often a sicker population who has to cancel because of other complex medical conditions. So these are some of the concerns that come up when we think about providing low vision care. And I want to talk about ways that we're addressing this now and also what you can be doing in your practices to try to make this a bit better. And I think one of the other keys that's come up as we've done some recent studies is that there is a general lack of practitioner comfort with integrating low vision into their practice. So at least here in the US, low vision is a part of the optometric curriculum. But unless you kind of start practicing immediately, it's pretty easy to forget the specifics of that component. It's true with any subspecialty, but there's a general lack of practitioner comfort with this increasing population. So we'll talk about some of those pieces as well. And one of the goals that we've been working on here in Boston and across Massachusetts, and with our colleagues down at Johns Hopkins, is to try to create a low vision rehab model that can be adapted for every community. So laying the groundwork and then figuring out how we can apply that in different communities with slightly different needs. So let's define kind of how I think about low vision, like I said, just to make sure we're all on the same page. So low vision is any permanent impairment of vision that causes functional limitations. And I would say typically we define it as impaired vision in both eyes, though I definitely see patients in my practice who are functionally impaired with reduced vision in one eye. We define low vision in terms of the visual acuity in the better seeing eye or the visual field loss. We also think about contrast sensitivity, though that is not as often included in the criteria. And low vision, as we all know, can be congenital or it can be acquired. I wanted to also include what the World Health Organization categorizes as low vision. So they categorize as mild, moderate, and severe. So mild would be a presenting VA worse than 612. Moderate would be presenting VA worse than 618. Severe worse than 660, which is the US definition of legal blindness. And then the World Health Organization doesn't categorize as blindness until 3/60. So there's a slight difference in terms of that categorization of blindness. Otherwise, pretty similar to how we look at things in the US as well as worldwide. And when we think about what really is included in low vision rehabilitation, it's vision loss that cannot be corrected by medical treatment, surgical treatment, or conventional glasses. I think the key, and for those of you that were listening at the beginning, as we were chatting about some of my clinic sites, it's that multidisciplinary approach. So in my practices, the team members often include me as the low vision optometrist. We are frequently working with a low vision therapist through the Commission for the Blind or a School for the Blind. We usually refer patients for home-based occupational therapy. We may refer for orientation and mobility training. Our school age patients will have care from a teacher of the visually impaired. And then you don't want to forget about the other kind of standard pieces. The primary care doctor needs to be aware of what's going on in the patient's vision. And there may need to be some mental health resources involved as well. So psychology, psychiatry, or social work. And then integrating the services of local agencies to see where they can bridge some of the gaps. One of the challenges we have here in Massachusetts, and I know that it's hard to call it a challenge, but we have a lot of organizations providing a lot of service. And it can be really overwhelming for patients to figure out what services they are eligible for and even where to begin to start to access what's available. So I view one of my roles in low vision rehab as kind of that care coordinator to get the patient connected to the right services. And then they usually will get a case manager that can take over. And I think it's important to know what the American Academy of Ophthalmology considers the preferred practice pattern, because I think that this really emphasizes what we're seeing in our clinics here. So the Academy of Ophthalmology recommends that you either provide low vision services or refer for low vision if a patient has reduced vision of 20/40, or that would be, I'll do the math, I believe that is 612, or worse, central scotomas, reduced contrast, visual field loss, or any complaints of functional vision difficulties. So they've really shifted away from that concept of not referring until a patient is legally blind. And they've even shifted away from kind of our typical 20/70 vision. So they're saying kind of any mild vision impairment should be referred early for low vision, knowing that the earlier you access care, the more successful you will be as you integrate low vision rehabilitation throughout your disease process. And when we look at the prevalence and the annual incidence here in the United States, the majority of patients who have what we would consider low vision are in this mild category. They're between 612 and 618, or between 2040 and 2060. There are many fewer who fall at the 2200 level. They obviously are very much in need of low vision care, but one of the things that we're learning is, excuse me, that primary care optometrist or ophthalmologist can often take care of that patient who's 2040 to 2060. They don't tend to need the most complex rehab strategies, and they can start to get comfortable with some of the tools available. In the US, there's been a number of epidemiological studies about the prevalence rates of low vision. And you can see on this graph that at about age 55, about 1% of people have vision impairment. But by the time we get up to age 80, we're climbing pretty dramatically. And by 85, it's about 10% of the population. These studies were only, this data is reported on the median age of the white population in these studies. We see it shifted slightly in other ethnicities, but this is the general trend that as people get older, the prevalence of visual impairment increases significantly. When we've assessed how many people are actually accessing care here in these particular study areas, so we looked at the Washington, D.C. metro area, so Maryland, D.C., and Delaware. We've looked at Massachusetts and we've looked at Tennessee in detail. Providers are only serving about 15 to 20% of the low vision patient need in the area. And that list of providers includes optometry, ophthalmologists who practice low vision, occupational therapy, orientation and mobility, and many others. So we know that there's a huge unmet need in an area with what prior to this study I thought was actually a good number of providers. I felt like, we're in the US, we have a decent number of people providing this care. Although it's hard to always access, I really thought we would be doing a lot better than 1 in 5 patients in need being able to access the care. And who are these patients in a little bit more detail that I'm seeing? So generally in the US, most cases of low vision are caused by age-related eye disease. So we're about 2/3 from macular disease, mostly age-related macular degeneration, but macular diseases in general. Diabetic retinopathy is the second highest, but it's quite a bit smaller than the number with macular disease, similar to the numbers of glaucoma, and just a few people still have cataracts that are inoperable here, so much lower number than you may see in other places. And then there's obviously other causes of diseases. We're actually in the process of we're waiting on IRB approval to do a retrospective analysis from our safety net hospital here in Boston, because my general sense is that my breakdown of patients I'm seeing is quite different than this in that population. I typically see 1 macular degeneration for 10 to 15 diabetic retinopathy or glaucoma patients. So we're hoping to be able to contribute to the literature to talk a bit about your less typical practices, but it's still seeing good numbers of low vision patients with different breakdowns of conditions. And just to reiterate, this is a study of patients who actually presented for low vision services across about 28 centers in the US. So it's a study of about 800 patients. And the median age of patients presenting was 76. The mean was 72, and only patients over the age of 18 were included in the study. So you can see it's heavily shifted towards older adults. So that's just something that we'll keep in mind as we talk about addressing the barriers and figuring out how to serve this population. And I think also really interesting and very true to what we were thinking about and what the Academy of Ophthalmology is emphasizing. This is again from patients who actually presented for low vision care. The vast majority were better than legally blind, so better than that 6/60 or 2200 acuity. So that tells you that although in the past we weren't necessarily thinking about referring patients at 2040, at 2050, we felt like that was relatively functional vision. A third of the patients who came in for low vision services in a 3-year period had better than 20/60 vision. And this is really the reason why. So if you look at how patients reported their vision and how they felt that their function was, sure, the patients at that 20/20 to 20/60 range rated their vision the best of the group, but nobody rated their vision on average as even fair. It was fair to barely fair for that slightly impaired group to poor across the board. So this tells you that we know that visual acuity is just one tiny piece of what we're looking at. And I think one of the things that you can do to help address some of these barriers is practitioner education to shift away from acuity. When you start talking to your referral sources, I have found that this slide is one of the most effective in communicating with those who refer to me, to really educate their technicians, educate their team members to ask the patient how they're functioning, even when they think the acuity is pretty good, because it just doesn't have that same quality to the acuity as your 18-year-old myope who can be corrected to 20/20. There's just a lot more going on in terms of the reduced retinal sensitivity, the contrast sensitivity loss, and the scotomas that are really impacting how those patients are seeing. I did a bit of digging. I know there's people on the call from a lot of different places, but I did a little bit of digging to get some information of what the situation is in India. There's some pretty good information available, so I'll just quickly go through the breakdown from what I found from this study. It was a well-done study of a large group of patients. So they were studying prevalence rates in southern India, and quite similar to the US, across the board, not specifying by age, the prevalence was about 1%. And we see that that's true here too, before you start to stratify by age. Similar to the US, retinal disease was the most common cause, but it was only about 30% in their study compared to our 60%. Amblyopia still comes up pretty high on the list in this particular study. So that's a topic for a different day about, vision screening in children. And I see Aparna nodding, but we know that that's a separate issue, but really important because it is affecting people in these populations. Optic atrophy, glaucoma, and corneal diseases were also common causes in this particular study. Much like what we see in the US and Canada, higher prevalence with increasing age. Again, similar to what we see here, higher prevalence with decreasing socioeconomic status, less access to care, less health literacy. That's pretty consistent worldwide. And there are a number of studies that report a much higher prevalence of low vision in regions in India, but often those studies are actually reporting on treatable causes, not just untreatable. So I thought that this was a unique study because it really looked at the untreatable causes rather than uncorrected refractive error, operable cataracts, those kinds of things. Those are a huge issue. Again, a topic for a different day. And this just shows the different regions as well as the levels of acuity loss. And you can see kind of similar breakdown that the more impaired vision is actually the little bit better numbers. So fewer people have the more severely impaired vision. And looks kind of like the graph I showed you for the US. The older people are, the higher prevalence of low vision. At age 70, we're getting up to about 6.5%. I mean, it almost exactly mirrors what we saw with the US studies. When we got to 85, we were over 10%. I would expect that if this study continued, we would see that same shift, that same older adults with a much higher prevalence of low vision. I would be remiss if I didn't at least quickly touch on pediatric causes, because there actually is a need for getting pediatric patients in for low vision services as well. It's not just about older adults. And one of the reasons pediatric low vision is so important is actually the disease burden is much greater, because the patients have the largest number of years per patient with vision impairment. They live their whole lives with the vision impairment. The common causes that we see here, toxoplasmosis, hereditary optic atrophies, cerebral vision impairment, which is a huge factor, especially in developed countries, optic nerve hypoplasia, retinal dystrophies, and I have optic atrophy there twice. Pediatric patients require that same multidisciplinary and collaborative approach. And it's absolutely essential to start providing the care early so that these young patients can learn to adjust to their vision loss and have successful lives, successful careers. And we can figure out, what is the best learning environment? Is it a school for the blind, or are these students best served in a regular classroom with some additional teaching and training? The team at LV Prasad did a nice study of the pediatric patients that present to their clinic. It's a little bit older study. The one I found was from 2002, but they did a cross-sectional review of 220 pediatric patients. And they found, again, most were in the moderate impairment category, not severe and not totally blind. Now, they're a specialty hospital. They are a private hospital, so it's going to be shifted from the general population, but it is interesting to know who's presenting there. And their most common causes were congenital glaucoma, hereditary macular degenerations, RP, and albinism. They also noted the significant role that refraction played in these cases. So when you're thinking about how you can start having an impact in low vision, don't forget about the basics. I have been to some lectures of low vision practitioners who say, don't bother refracting, the patients are visually impaired. There's a huge, huge difference between 2200 with clear vision and 2200 with refractive blur. So that is, just don't ignore that piece. And I think when we're talking about pediatric low vision, these kids can also end up with overlying amblyopia. Many of the kids, particularly with albinism, have high refractive error, and they may have strabismus, they may have other things going on. So you don't want to ignore the basics. And I think that this study would have had a very different breakdown if it was looked at now, because I think that LV Prasad is having a lot more cases of cerebral vision impairment presenting now that we have a better understanding of CVI and how to diagnose it. And also, we're seeing worldwide increasing numbers of CVI because we're able to provide really, really good NICU care. So the neonatal infants who are born prematurely are surviving, which is really wonderful, but they're often experiencing cerebral vision impairment because of that lack of oxygen or other birth trauma. So studies generally do show improved visual function with low vision aids in the pediatric population. And you just have to remember to adapt the exams to figure out good visual function and appropriate interventions. It's often a team approach, and we use a lot of creativity. That we can talk about pediatric low vision exams another day, but I just don't want to forget them and focus only on older adults. So when I think about low vision, and this is another way that I'm trying to shift the thinking to get more people practicing low vision, I think about low vision as primary versus advanced. And this has been adapted by the schools and colleges of optometry in how we teach our students. So we want everybody who graduates optometry school here in the US to be comfortable with primary low vision care. So that includes spectacle solutions, prescribing high ads, thinking about single vision prescriptions. I hope everyone listening today is saying, well, of course, who wouldn't do that? But you'd be surprised. I hear a lot of my students say to me that, a plus 250 is the highest they'll ever think of going. We can do a lot with spectacle solutions, and you can do it in a primary care exam. Picking up the trial frame and doing a proper trial frame refraction, beginning to incorporate basic magnification, and educating the patient about their disease and about the additional services. This is all steps that can be taken by primary care optometry clinics. And by getting the patient comfortable here, you might increase your success in getting them referred for the more advanced care when they need it. So in terms of advanced care, this is more of what I do on a daily basis, but it's really looking at the higher powered magnification, digital solutions, telescopes. I think most primary care practitioners aren't so comfortable in incorporating telescopes, referring for technology assessments and doing some of the technology in my clinic, optical character recognition, computer accessibility, considerations for vocational rehabilitation, and some of the sensory substitution techniques. So talking about tactile markings, really integrating auditory information. So just as we talked about the World Health Organization categories of visual acuity loss, so I think we all know here in the US, if we're using the 20-foot numbers, so 20/20 would be our normal vision. 20/40, you can drive without restrictions in almost every state in the US. So that's again 6/12. 20/60-ish is typically reading newsprint. At 20/70, Medicare says you can get low vision occupational therapy and rehabilitation services. They will cover it at better than 20/70 if there's a visually significant scotoma or contrast loss. But Medicare is still using a particular cutoff based on acuity. At 21/25, you're eligible for blindness-related benefits in the US. This used to be 2200, but they've shifted because of newer charts. The ETDRS chart and most of the digital Snellen charts have a number of lines between 2100 and 2200. And patients were becoming disqualified because their doctor had a more sophisticated chart. So they did update those requirements to allow for benefits there. And you can see again that mild low vision in the US, it's 2.5 million compared to only 1.25 million at the severe level. So that mild category can really be served in a lot of different ways. And we need to be thinking about how we reach those patients and how we reach their referrers to help them understand that that is an area of need. One of my colleagues, Dr. Jamara, built this low vision decision tree to kind of help your primary practitioners think through what they want to do for the patients. I really like the concept here if you're not so comfortable with primary low vision. I particularly like that the very first thing he talks about is that if the visual acuity is not correctable, go to the contrast sensitivity and figure out, what does the contrast show? Then you go to the scotomas, then you re-divide based on the severity of the acuity. So this really gets at that kind of first concept I talked about, that acuity doesn't really give us a good sense of functional vision. So we broke it down by contrast, scotoma, then acuity again. And then he talks about suggestions for spot reading versus fluency. This is not something I use in my clinic on a daily basis, but I have kind of gone through the way I treat patients retrospectively, and this is how I'm practicing low vision. I think anyone who's an active practitioner would look at this and say, yep, that makes total sense for how I have my flow. But if you're trying to teach new practitioners, this can be a really nice way to help them think through, what do I do, instead of feeling like it's a trial and error as they go through this huge range of devices. And now to really get to the meat of the topic is, what are the perceived barriers? So I talked about some of them in the beginning, particularly that issue of providers not feeling comfortable. The decision tree is one way to help, kind of emphasizing primary low vision is another way to help. Practitioners can become more comfortable if they don't think that they have to worry about computer technology and knowing every app available. But there are two studies, one that we just published actually in January, which was US optometrists' reported practices and perceived barriers. We were specifically focused on that mild vision loss category because that's what we wanted to understand, since there's so many patients in that area. And then there was a slightly older study looking at perceived barriers to providing low vision service among ophthalmologists in India. So theirs was with ophthalmology as opposed to optometry. It doesn't really matter. Each of these studies kind of talk about very similar barriers. So what we found in our study first was that most people aren't doing even the most basic low vision strategies, as we talked about, the high ad powers, low magnification, things that seem fairly simple. And we found that was true amongst practitioners who do no low vision whatsoever. As soon as people put on the survey that they did some low vision, then they were more likely to do kind of the basic things as well. But those who identified as for private practice or commercial or other settings, but as primary care optometry only, weren't considering these basic low vision strategies. The barriers that were reported in this US study, and it was a few hundred optometrists who completed the surveys across different states and different practice modalities. The cost of the exam and cost of the devices were seen as a barrier. That's something that's easy for us to overcome here in the US because actually the exam is covered by medical insurance. But it's clearly an issue. It was the #1 reported barrier. So we need to do better education to practitioners about that. There was an assumption among practitioners that patients are not interested or would not go if referred for low vision care. That's a bigger barrier to tackle. And practitioners reported that it wasn't feasible to have the devices in their office, both to assess the patient and for the patient to be able to order if it were prescribed. In India, actually, I think pretty similar breakdown. So they did actually specifically find that lack of training as an issue. So we can talk about ways to get that training out there. They talked about a lack of awareness and availability of services, kind of not knowing where to refer. This lack of access to low vision devices was reported in both studies. And they also noted a kind of an assumption about lack of motivation from the patient. So I think that's really interesting that both groups surveyed mentioned the device issue. Devices, I think that's actually really pretty easy to solve. There's a number of ways we can address that. But the practitioner assumption regarding lack of motivation is particularly concerning to me. And that's one of the things that we have to kind of look at other ways to get the information to patients. And over time that we have to help practitioners kind of shift away from their inherent biases by helping them understand what low vision rehabilitation really means and why their patients are more likely to be motivated to go in than maybe they're giving them credit for. So to kind of summarize the barriers that we've seen, so one that we talked about is that low vision is kind of slow, takes up too much chair time. I think that is kind of echoed in the US practitioners' concern about cost. Even if they get reimbursed, will it be enough to justify the time they're spending? We talked a bit about low vision being kind of the no-show, harder for patients to get into the clinic. Low vision requires devices. We saw that in both surveys. There's concerns about device access. A lot of practitioners have concerns, well, if I can't stock the devices, why am I going to bother? And that, once I see that patient the first time, are they going to become kind of this repeat patient that I'm going to have to invest a lot of time into? Or are they going to even be able to come back if they travel a distance to get to my clinic? How do I do this follow-up and what happens? So when I did a lecture similar to this some years ago, one of my friends came up with our cartoon to break through the barriers. So I like this clip art, so I kept it in there. But how do we really address these? So one of the things that's been pretty effective here in Massachusetts is actually using community outreach to address the referral rates. So we do lots of education with our optometry students, with our optometric colleagues. We do a lot of education with the ophthalmology residents and the ophthalmologists that I work with. But, they're really busy. They're seeing a lot of patients in the day. And we saw there is this inherent bias amongst both optometrists and ophthalmologists that perhaps the patient won't go for the service. So we've actually trained Lions Club members here in Massachusetts to do community outreach programs. So they are going to their own optometrists and ophthalmologists and mentioning, do you know about low vision services? I went to a talk and I learned that this could be helpful. Here's a brochure if your patients are interested. But even more importantly, they're going into senior centers and they're doing education programs as community members. So they're the ones coming in and saying, I took my neighbor to a low vision visit and it was really beneficial. And what we're finding, I do lots of these talks and I don't get referrals from them. I get patients who thank me for being there. They say, this was great, I'll take your card. We don't really get follow through. When my community members have been going into their own communities, they're getting phone calls, a couple of days later. What you said really resonated with me. Can you help me get an appointment? I think my mom could really benefit. Can you help us coordinate that? So I think that removing that barrier of having a healthcare provider giving the talk is helping some patients feel comfortable reaching out and asking for the service. They also become more aware as they attend these community education programs, and they may go back to their own doctor and say, oh, I went to a talk on low vision. Do you think it would be helpful for me? And now they're helping with that inherent bias of a non-motivated patient because the patient is actually showing motivation. We also need to do increased training of our primary eye care providers. I think you all know that. I mean, we're emphasizing it in our optometric education programs. We're trying to ensure that every intern has an experience with a low vision patient. We're doing a lot more hands-on active learning. We'll see how it goes this fall, but last fall, pre-COVID, we were able to bring in actual volunteer patients for our students to examine. And we did a continuing education program at the beginning of March, where we did the same thing. We had volunteer patients come in and sit and let practitioners who hadn't done low vision in a long time perform refractions, perform near assessments, fit them in bioptic telescopes. We had hemianopic patients come in and sit for visual fields and for Pele prism fitting. So these active learning opportunities, I think, go a lot further than your just typical continuing education as well. And those can really improve referral rates in addition to the community work. We also like to emphasize that, you know, your primary care optometrist often refers directly to ophthalmology, but they don't want to refer to low vision at the same time. They kind of want to defer to the ophthalmologist. And I actually think that the referrals can all happen at once. You know, the patient can space out the appointments as they need, but we all really work together. So the ophthalmologist can refer back to the primary care OD, they can refer to the low vision OD, but it doesn't need to be a one-way street in referring. I think everyone works together in that team approach. We want to start improving care delivery. I think the more we can publish on effective outcomes, the more we will kind of reduce that inherent bias. So if we can get some other research going that measures patient-reported outcomes, and then within low vision practitioners actually educates the practitioner about how they're doing. So I don't know how many of you have listened to Dr. Bob Massoff from Johns Hopkins speak, but you know, he always says, it's really nice if your patient comes back and bakes you cookies, but how do we know that we actually effectively helped them? Sure, they feel good. We all spent time together. We pat ourselves on the back and we say, well, they brought me cookies, they must be happy. But are we actually improving outcome measures, and how do we become better practitioners? So this is a piece that they're working on quite a bit at Hopkins, and I think just keep watching for some published literature coming out of there with how they give that feedback back to practitioners. They did an interesting study a few years ago, and this again goes to our inherent bias, but they asked practitioners to rate the likelihood of successful rehabilitation for their patients. So after that first visit, the practitioner filled out just a quick kind of Likert rating and said, you know, I think this patient will be very successful, or I think this patient won't be successful. And the quick summary of that is that we are really, really bad at predicting who is going to succeed. So the more that we can shift away from those biases and can really offer the patients the opportunity to go to low vision and make the decisions for themselves, the better off we'll be. And as we start to learn what we're doing right and wrong, hopefully we become better predictors. But right now, these were experienced low vision practitioners in that study. I was one of the people in it, so I can say we did a really terrible job predicting who would be successful. You know, how do we improve who shows up to the clinic? So we are using some Lions Club members again here, but also our staff members to help coordinate some of the transportation issues. That is a big problem. I imagine that is a worldwide issue, that getting to the clinics, especially people from rural areas, can be difficult. But we're trying to do some in-home follow-up. And I think even more importantly, what we've been seeing right now with COVID is that we're trying to reduce the amount of time the patient is interacting one-on-one with the doctor. So the less interaction, hopefully the less risk of them getting sick. And so we're doing histories over the phone ahead of time. And we're finding that the patients are having a better understanding of what to expect from the visit, and they're more likely to show up. So instead of it being, I was referred because my doctor told me I should go see you, they've now already gone through some of the challenges that they're experiencing, and that staff member can say, yes, this is something the doctor will address with you. And it helps them be just a bit more confident in what the appointment is for and why they should go in. This was also done through some of these outreach models over the last few years in Maryland. And they found that they did have a better rate of patients coming in for appointments if they had done a partial history ahead of time. It also reduces chair time. So that concern about, I'm spending too long, I'm not going to get reimbursed, I have too many patients to see. If the patient has done a lot of this ahead of time, then they don't have to spend as long in the clinic. And we're also looking at telemedicine follow-up visits because that, again, reduces the burden on the patient coming back for additional clinic visits. It also tells you a lot about how the patient is functioning in their home. So if you ask them to do the telemedicine visit in the place where they do their reading, you can start to get a better sense of, is the lamp actually positioned where they told you it was? Is it as bright as they say it is? There is a technology barrier here, but we've been pretty successful in getting patients to do the telemedicine visits. We're looking at some models of even mailing out a tablet with some eye charts and then having the patient mail it back. It does require a certain amount of trust that they will mail everything back to you. But in our initial pilot studies, the patients have been great about returning the equipment and participating in telemedicine that way. So this is an example of what they were using in Maryland for the phone history. This is the report that the doctor gets. So if you're thinking about saving time, the doctor gets this summary of how difficult is the reading and how does that reading difficulty rate to the 3,000 other patients in the database. Talks about their living arrangements, their sources of assistance. They're actually doing a depression scale, a cognitive scale ahead of time, a physical functioning scale, and they're coming up with just the overall goals. So much of my time in a low vision exam is figuring out what the patient wants to do. So if they come in and I have this information and I know that number one is they want to read their mail, number two is pay their bills, and number three is food shopping, I can now really target my exam and perhaps save that 20 to 30 minute history. I have piloted using this type of survey. This is based on the activity inventory, which is an adaptive questionnaire. I didn't have as much success in Massachusetts as they had in Maryland. For those of you who know the geography of the US, the Northeast tends to be just a little bit more reserved, a little bit more conservative, not as willing to give this information over the phone. Maryland and actually Kansas and Nebraska, they were really happy to talk for hours and give all their information. So we're looking at how we can modify to a shortened history just to gather that initial information about goals. I don't think we're going to have as much success with the depression scales, the cognitive scales with our patients just based on the initial work we've done. So now thinking about all of those pieces, what are the kind of the essential components to have in your clinic if you want to start breaking down some of these barriers? So I am a big fan of making sure you have an ability to test contrast sensitivity. So the Mars chart is really portable. I carry it with me clinic to clinic. There are a number of charts available if people don't read English letters. So they're called the cam blobs, which are just, you point to where the circles fade. And Dr. Ian Bailey has developed an iPad app, which has blinking squares. Great for pediatrics, but also great for patients who don't read English. They point to where the square is blinking. And this gives you a way to measure contrast sensitivity. I always like to include kind of what I consider my absolute essentials if you're doing primary low vision care. You really don't need a ton of equipment. 5 handheld magnifiers, a couple of stand magnifiers, some prism half-eyes, and some filters, and you can really serve a lot of those patients in the mild to moderate range. There are some fantastic resources available for low-cost, low-vision aids. You don't need a premium handheld magnifier to assess your patient. I know that the Hong Kong Society for the Blind has really good low-cost magnifiers, and there are a couple of groups in India producing low-cost, good quality magnifiers. So I think that shifting away from this concern that a magnifier is going to cost your patient, a few $100s, they are available for less money. Are they as good as the most expensive? Maybe, maybe not. Maybe the LED light is not quite as good, but they are far better than saying to your patient, this is an unaffordable option. We use these lower cost devices a lot in our clinics. We use them a lot with our pediatric patients and our geriatric patients who are worried they're going to lose them. They want one in every room. It falls out of their purse, it breaks, so they don't want to spend $200 on a device. So think about kind of what do you need to assess the patient, how can it work, and can you incorporate some low-cost tools? If your patients are relatively tech savvy, show them the magnifier apps. I heard someone mentioning on the phone that they do some teaching on the digital technology. There are a number of really good free apps for smartphones that let people magnify without having to purchase another device. And we're seeing more and more people with access to a smartphone. That's how they're accessing the internet. And that's what I use for a lot of my patients. Here in Massachusetts, our Medicaid, our state-assisted health insurance program, will provide a smartphone for free. Again, it's not the latest, greatest iPhone. It doesn't matter. It has internet capabilities. You can download an app to magnify, and you can enlarge the print on the screen. So you have a way to help your patient really access their care. So, take advantage of your community volunteers. I've been really, really impressed with what Lions clubs have done here. Like I said, they do their outreach to their own doctors. They've been doing public education. They're that community resource. They're the person who can say to their neighbor, I noticed you're having more trouble with your vision. Have you heard about these types of services? They can also provide transportation. They can do some of the in-home follow-up. That's a bit more complex in terms of setting up, but it is something that is going on in some parts of the US. And they can do those histories before and after. Again, you have to think about privacy training and computer training, but it is something that can be done. And so, basically, as I mentioned before, we really do want to provide real-time feedback. And kind of the last piece I want to mention is, as we've talked about, so these community volunteers have done a lot of outreach and they're providing a lot of information. And we've done some in-person training programs. So we did 2 14-hour trainings over the last 2 years. And in those 2 trainings, we had more than 50 providers trained in both primary and advanced low vision skills. And we're finding that these practitioners are reaching out to us as the more advanced practitioners as they run into difficult or challenging cases. They are referring the patients to us and they're working with us as they're increasing the amount of low vision that they're doing. And the next step and the final piece I'll mention today is that we're actually setting up telemedicine consultation to assist these new providers. So the Veterans Hospital in Buffalo, New York has been doing these types of telemedicine consults. And what we're proposing is that a doctor at our clinic will be available through video while the provider has a patient in their office. And through that video, the more experienced practitioner will be able to provide insight into the potential devices, what community resources may apply, and even additional history questions that the practitioner may want to ask. So it's the way that I work with my interns, you know, they come and present to me and we go through it. But if you're an experienced practitioner who wants to add this service, you really don't have that support the way you once did as a student. And so we're looking at how we can provide that support to our new practitioners to really increase the amount of services being offered for low vision. So my quick summary, we've gone through all of these different ways that we can provide solutions. And we know access to care is an increasing challenge. We know there's increasing incidence and prevalence. And we really have to think about different models of practice, different ways to integrate telehealth, telemedicine, and even shifting our thinking about patient motivation to make sure they get the care that they need. And then just some references.
Lexi, that is one fantastic talk. Such clarity and clear explanation, and I think telehealth is here to stay, and I think it's going to make care for patients easy access, especially for the older cohort to not commute and come in. So I think it's going to be revolutionary, and it's interesting to see your insights on the barriers and the questionnaires that are being developed and so on. I'm going to say, I think there was a question. I'm going to unmute you, Puranji. I think you had a question. I unmuted you.
Thank you, Dr. Malkin. In India, the meaning of Malkin is landlady. So you are the doctor lady. My question is that you said that the practitioners are not motivated to see the LV patients. Why can't we improve it? It is the government or it is the Society of Optometrists. So they should be motivated to see people with LV, and that will make a lot of difference.
Yeah, I think it's twofold. So it's in part that the practitioners aren't motivated to integrate the care, and also that they're assuming the patients don't want the care. So the first piece, I think you're right, the more that we can show practitioners real life examples of how low vision is effective, the more as a research community that we can publish data showing that we have good outcomes and that we can reduce some of these factors like chair time, I think that will help practitioners be more motivated when they see how, not just how rewarding it is emotionally, but from a scientific standpoint, that it actually is effective care. I think that, you know, we have to really take that medical and scientific approach to show people it is effective. Placebo-controlled studies show it's effective. This is why you either need to do it or you need to refer. So I think, you know, we're trying it through having all of our ophthalmology residents rotate through low vision clinics, and ensuring that our optometry students have a valuable low vision experience, not just a course. I think, you know, when Aparna and I were students, I loved the people who taught our course. I would not say that I left inspired to provide low vision care from the classroom learning. It was really the patient interaction. And I hear that from my students now as well, that the more that they interact with people who have vision loss, the more that they realize how critical optometry and ophthalmology is to providing that better quality of life.
Lexi, this is Lubaina. I'm an occupational therapist, and I thoroughly enjoyed your talk. I think, like Aparna said, it was extremely detailed and, excuse the pun, quite an eye-opener. But I think what I got from your talk is optometry faces the same, or low vision optometry, so to speak, faces the same societal hurdle as occupational therapy does. Practitioners and physicians do not fully grasp the value or the impact of these services. And I think, like you rightly mentioned, I think the onus is on both ends. We need to create something that is more visible, more studies on the efficacy of our approaches. And I think optometry, I work in a public school setting, and my experience with low vision is related more to CVI, children with CVI. But then I see this in India, having, from India, and coming from a ophthalmic background, family filled with eye surgeons, I do see this disconnect in their knowledge of what low vision services encompasses. And the gamut of the whole team approach. I think it's really well established in India in, I would say, settings or hospitals, that have a low vision center. A lot of the work Vision Aid does in India is with these centers. But with isolated practitioners, just like in the US and India, I think that's where we need to focus a lot more of our outreach.
I agree. And I think even in the best centers, I was sort of shocked when I read some of the studies. They did a study in Montreal about access of low vision services, and it was in an ophthalmology clinic with low vision in the same building. And they had a slightly better than that 1 in 5, but not a whole lot. I think I haven't spent a lot of time looking at the groups in India, but I did spend some time at LV Prasad a few years ago. I think they have a pretty incredible model of getting people in for low vision. I think, that's been years of work of educating practitioners. But it's pretty shocking to see, even within our own systems where we have low vision available, the referrals aren't being made, or the patient is not understanding why they should go once the referral is made. As you said, it's both pieces. It's not just blaming the doctors. I think we as optometrists and ophthalmologists and occupational therapists and providers are trying to get that information out there. But there's just a disconnect on that follow-through piece. So though I just went over some of the strategies we're trying, I think it's a lifetime challenge of really sorting through this.
I agree. Thank you.
And I think luckily it seems like the pediatric practitioners at least are starting to identify when CVI referrals need to happen, at least here. But the practitioners here, I think, tend to be extremely well educated in Massachusetts, and we still don't get great referrals. But I think CVI, it seems like, is being caught a bit more, at least from what I'm seeing, kind of who's showing up in the clinics where I am.
Yes, and I think most of my kids with CVI, come from the bigger, are followed by the bigger institutions like Children's, and it's usually. I've actually taken the onus of referring kids that I suspect, based on their birth trauma, that there might be some more CVI related issues going on, to refer them. It has not come from their primary care physicians. So again, it's not just the ophthalmologists, but I think it's also the primary cares that are not quite aware of, what low vision services could be.
Yeah.
So
And the geriatricians and we've got to kind of hit it from all sides, because often the patient is looking to that provider to give them the okay before they pursue additional specialty services.
Mm-hmm. Yeah, in fact, one of the things we are doing, great talk, by the way, fantastic. Just took so many notes. I'm going to watch the recording again.
I'll send I'll send the PowerPoint as a PDF.
Yeah.
So you can post it with it. So if people want to download the decision tree or they want to see the references, they can have that.
Yes, that's fantastic. But just wanted to mention that one of the partners we work with in India, it's a large hospital, and they're trying to tackle this issue technically by introducing a system change so that every patient who goes to any part of the hospital now has to, the care provider has to enter, whether the patient has low vision and whether they're sending a referral, and if they're not sending a referral, why? I mean, so they're kind of introducing this at a technical level, so it kind of forces people to actually pause and think, and it's like a mandatory question they have to fill out, so they can't bypass it. So
I'm really interested to hear how that works. I know that that's something that the team at Hopkins is looking at doing as well, kind of having a flag pop up in the Epic medical record system to see, like, does this patient appears to have low vision? Are you making a referral?
Yeah. And it's not an option. It has to be a mandatory question. They have to say yes or no. And if the patient says yes, I mean, if the provider says yes, the patient has low vision, they have to fill out whether they referred or not. And if they didn't, then they have to say why. So,
I mean, it's smart. It's what we have to do with medication allergies. If you're going to override it, you have to give a reason.
Yes.
Yeah, I'll be really interested. I assume they're going to kind of study it and see and present some data on how that works, because I think in the larger centers, at least we can address that barrier. That second issue of these more isolated providers is a whole different thing. But
right. So we'll get you that information for sure.
Great.
Anyone else have any other questions before we go?
Yeah, hi Ram, thank you. This is Ali Rizvi Lexi. Wonderful talk, and I have a lot of takeaways from your wonderful discussion you had today and shared with us. More so about those three ideas about the use of telemedicine. And these days, as we are getting used to becoming more comfortable socially or zooming in, rather, should I say, that the more patients can be seen in their own confines of wherever they are, the comfort zones that they are. If they're not coming or not able to come to clinics, that was one. And the other was the use of the organizations like Lions Club you mentioned, and they can play a very important and crucial role as reference groups that they can influence those who are suffering to understand how easily they can be seen by a doctor. So, and the third, I think, was the kit you mentioned, that you carry a small kit with you. If that was available in most of the places, in settings in doctor offices, that would also be able to have a higher level of people being seen on their first visit as far as low vision is concerned. So thank you, Lexi. Really wonderful talk.
Yeah, and I used a Lions grant to get that kit into about, I think we're at about 15 practitioner offices in Massachusetts. We get it from the Carroll Center to support kind of our local group, but you can get it through Lions as well. But yeah, that seems to at least reduce that one piece. And the full kit with digital devices, we're talking $2,000 to $3,000 if you include the Mars chart, if you include the near cards, if you include this full range. So for a practitioner in the US, that's not way less than the OCT that they're buying, or than the visual field machine that they're buying. So we're trying to see if we can start to encourage practitioners to obtain those as well.
Great. Thank you.
Yeah. And Lexi, Mr. Rizvi, who just spoke, is with Vision Aid. He's the president of Vision Aid. So
Wonderful.
Just to make a connection.
You guys are doing really great work.
Thank you.
We really appreciate your coming and taking the time. This was a very, very informational talk. We're going to place it on the VisionAid Online Academy. And from there, it propagates into all our partners and to others as well. I mean, we're actually creating a whole range of courses. So this is actually going to become one of them. So I mean, the talk will live on for a long time.
I'll add my email address to the intro slide. That way people can reach out if questions come up. And low vision's a small community. So it's always a good way to be able to connect people. And
of course, yeah, we'd love to stay in touch with you. And exchange ideas. Anyone else have any other questions before we end the talk?
I had a comment, Lexi, that yes, the technology is going to bring change. We are seeing that, we are learning that, and initially we had difficulty. And recently, when we looked at retrospectively our data, we found that the referral has become now sooner than the way the time gap which was there by the way identification of patients with visual impairment used to happen, and the referral duration. Now it is reduced at tertiary level because of the periodical training in-house. So in-house only we looked at the data and we found that. And today itself we saw about 20 patients with the tele-rehabilitation. So yes, the follow-up rate may probably improve. That was again an issue which we were facing. And because of this COVID, we started exploring this tele-rehabilitation, and it's working. So we are looking forward that how technology is helping us to overcome these barriers.
yeah, we've been having some good success. We've been doing a lot of our device dispensing visits with telemedicine. So we're shipping the device to the patient and then connecting with them by video. And it's really great. The patients seem to like it quite a bit. Many times if they can't set up the video conference, they have a family member who can. And prior to COVID, we were actually training, again, Lions Club members to go into the homes to set up the iPad for the telemed visit. Once we're allowed to have people back in others' homes, we're going to do that again. But we're doing a pilot study on that with, it's actually not even a pilot anymore, with UCLA and with us and with a couple of other sites. Again, seeing can we get volunteers to assist when patients either don't have the technology or just can't use it.
Yeah.
So Lexi, another thing is that it's good for follow-up, but for new patients to examine, assess, is tele-rehabilitation can help us decide the prescription of device. History taking, the counseling is okay, explaining that what to expect, but prescription of devices, how do we go about it?
Yeah, we can't do that yet. We can't refract, and we can't prescribe a device. Yeah, I've done a little bit of smartphone training with telemedicine.
Okay.
But yeah, you really can't, even if you know the acuity, even if you know the reading speed, you know the contrast, you still really need the patient to use the device and work with it with you. But it's good for histories, it's good for follow-up, and it's good for some of the counseling. I think sometimes the patients just need that immediate referral to vocational rehab. So maybe you can skip a step and get them into that more comprehensive service.
Okay.
Yeah, thank you, Deepa. Great questions. And as Lexi mentioned, LVP is doing excellent work, so we'd love to hear from you as well.
It's always nice to see you too.
Thank you.
Any other questions before we close? Parikshit?
She's answered all of them. Yeah.
Great. Yeah, Lexi, Dr. Gogate, Parikshit Gogate is from CCF in Pune, which is near Mumbai. And they're part of our VisionAid network now. So we're going to be starting up a new center in Pune. So.
Wonderful.
Thank you.
So.
All right. Well, thank you all.
Thank you all for joining. I'm going to stop the recording now.